Hello, this video is a small portion of a complete comprehensive video. If you'd like to see this complete comprehensive case and many other complete comprehensive cases, click on the link in the description below. And I begin with a 30 gauge needle with Sit-Nest 4% plain, and then follow that with a 27 gauge long needle with lidocaine 1 to 100,000 epinephrine. You notice I was giving an intraligamental. If you're extracting teeth or doing endo or anything like that, this is a practice enhancer. If you'll do this, you have to give an intraligamental. Many times you won't get the tooth completely numb if you just give a block or infiltration. So you have to give an intraligamental, and you do that with a 35 gauge short Sit-Nest 4% plain, and angle the bevel toward the tooth into the sulcus. In this case, after you've already given the mandibular block, so it's not painful when you give the injection into the sulcus. If you just went straight to the intraligamental, that would be uncomfortable. So all right, now this is going to be tricky because look at this root. The dilaceration, or the curve, is this way, is mesial. Not if it was distal, that would be an easy extraction to just roll out of there. And you think, okay, that's it's a super erupted tooth. It is erupted, so it ought to be easier than an impacted. Sometimes erupted teeth can be more difficult than impacted teeth, and this one happens to be because of the direction of the dilaceration of that root. Okay, so I'm first trying to just get some mobility. Dr. Cosentino was one of the oral surgery instructors when I was in that oral surgery fellowship. And he used to say, let the blood work for you. In other words, let the blood get into the periodontal ligament space and just loosen that tooth a little bit. So if you can get a little elevation and a little mobility on the tooth, even if you're extracting it with forceps or elevating it, that makes it an easier extraction. So that's what I'm doing right here. I want to see if the tooth will elevate out. I'm using the cowhorn forceps because those will elevate it up and out, up and out. I know I've got to go up because it's probably not going to elevate distally because of that root. So again, trying to get movement and see if it'll elevate up and out. And it's much more difficult than you would think at first glance. I'm trying to get movement and see if it'll just go out, so it won't. So after a point, I'm going to section the tooth and take it out in two pieces. This is a long shank, number 4 and number 6 round burr, and I'm using an electric handpiece. I'm not using an air-driven handpiece. So I've got my 2x2 in the mouth blocking the mouth, so only the coronal part came off. So this makes it trickier. If only the coronal part comes off, you've still got the root in the socket. So we'll see if the root will come out with the mesial half of the tooth. Okay, so now what I've got, I've taken the crown off the tooth, which, you know, just don't panic. You just have to deal with it. I'm going to be sure I've got plenty of flap elevation so I can see what I'm doing, and I'm going to section the pieces, the remaining parts of the tooth into two parts, and I'm going to remove a little bone on the facial. And now I'm creating a purchase point in that mesial aspect and try to elevate that. So if I can get one of the pieces to extract, see I've got the 2x2 in here, extract one of the pieces, then I can move the other piece into that space. Remember, when you're taking out teeth, one of the big things is space to move whatever you're elevating into. Because if you don't have any space, it's not going to elevate. The only way you can go is up. So I need to create some space distally if I want to elevate that distal root. If I want to elevate the mesial root, I've got to create some space in between the two roots. So this is just one of those teeth that turned out to be more difficult than I anticipated. So I'm creating a little space in between the two roots and a little space on the buccal. Now if I don't create any space distal to the distal root, I don't have anywhere to elevate that distal root. And remember, it's curved this way, dilacerated this way, so when I try to elevate it, it's going to be blocked by the distal dilacerated root tip. So I know if I want to elevate that one, I've got to create some space distal to that root. The only other way I'm going to elevate that root is by taking out the mesial part of the root and elevating, I don't want to confuse you, the distal root into that mesial space. So I'm sectioning between the roots. Now you need to keep in mind how much space there is between the parts you're sectioning and the nerve. You can measure that on the periapical radiograph, which is 1:1. So we're still just creating space. There we go. Now we got that by putting a purchase point in the root and elevate it with the Potts crossbar elevator. You know, the hole was large enough to put that elevator in there. So sometime if you can't get between the root and the tooth in front of it with the instruments, just making a hole in the root and elevating it either with the Potts or the E8 is effective. Okay, now we're getting the distal root. And you know you've got all the root when the part coming out looks like a root tip. So there's the socket. You want to be sure you get the follicular sac because that could potentially form into a dentigerous cyst if you left it in there. So this is the socket after the root tips were extracted. And now I'm going to pack it with an Osteogen plug. You may remember if you've seen my other videos, I used to do it, pack the sockets with a medicated resorbable gauze, which works well, but this is so much simpler. These Osteogen plugs are fabulous. I find that it's very good for hemostasis, for bleeding. It packs really well, and the patients have minimal pain. Once it gets wet, it really conforms, and you can pack it in with a large plugger. Then I'm going to put 2 3/0 gut sutures, which I normally put 2 sutures in when I'm suturing lower wisdom teeth, just because the incision is normally longer than with a maxillary wisdom tooth. So the key to not getting a dry socket is not lose the blood clot. And so you want something in the socket if you've done anything to the bone, if you've had to create space or do something with the bone that, so that you're drilling into the bone. So this is what it looks like after the Osteogen plug was placed. So what you're doing with the Osteogen plug and the blood in the socket is just you're covering the nerve endings in the bone for 7 days. It takes 7 days for a connective tissue lining to form in the socket. So you want to preserve that blood in the socket for 7 days, and that's what a Osteogen plug or the resorbable gauze does. It's a matrix to hold the blood clot in the socket. And it only needs to be in there for 7 days because after 7 days, you've got a connective tissue lining. So again, I'm giving an intraligamental. I've already given an infiltration. That's the dental minute. These techniques work, and they work every time.
Are you ready to take your dentistry practice to the highest level possible? Of course you are! Subscribe right now to dentistrymasterclasses.com where you will get Dr. Cutbirth's greatest work and best cases. Here's what you're going to get when you subscribe to dentistrymasterclasses.com. Incredible comprehensive cases not seen in Dental Minute videos. You will get an organized library of all the Dental Minute videos and Dentistry Masterclasses, comprehensive cases for study and reference, before and after photos of Dr. Cutbirth's fantastic restored cases. And all of this, I repeat, all of this is just $40 a month. This is something you cannot pass up. Subscribe right now to dentistrymasterclasses.com.